Very much for your kind introduction. I'd like to thank the local organisers, and I'd like to thank IACTA for inviting me. Previously, many Indian doctors came to the UK and worked in the NHS and worked very hard, and some settled. So it gives me great pleasure to come back in the other direction to India and to see the world-class healthcare, particularly in cardiac services, that you have here. And from my hospital visits and from this conference, it's clearly very impressive what you have here. As you know, there's things being going on at home, and we have this thing called Brexit, where a narrow majority of our people have voted to leave the European Union. So we're looking for friends in other parts of the world now. So the England cricket team was specifically instructed to lose all their matches to see if we could establish a better trade deal maybe with India. But I'm here really to talk not specifically about clinical things, but sort of a broader questions. And these are the three questions I'm bringing to you. So I'd like to ask, can measuring, comparing, and publishing outcomes lead to improved quality? Second question is, should we be collecting mortality outcomes by cardiac anaesthetist? And should we publish this information? This is a question we've been asking ourselves, and in other healthcare systems they've also been asking this question. And finally, how can we measure the quality of our post-cardiac surgical intensive care? You may have seen our badge on the first slide, and I was listening to some of your president's comments about critical care, and we actually have rebranded our society, and we've become from ACTA to ACTAC. We've added critical care on, I think, to really signify to surgeons and intensivists that we're the guys who are managing critical care. It's very important. It's a rather chilling quote from Joseph Stalin, and maybe this describes some of the healthcare outcomes research. So let's have a look at coronary artery disease. And you can see this is sort of quite early, large-scale health outcomes research. So in 1995, the OECD looked at the incidence of death per 100,000 people from coronary artery disease. And you can see the incidence in 1995 was quite high. And in the UK, we were amongst the worst nations with the highest mortality. And it was very interesting because there was a huge emphasis there in the UK, back in the UK then, on developing cardiac services. And there was an expansion in surgery, there was an expansion in cardiology services, rapid access chest clinics. There was a huge development in services in response to this data. And I think the same happened across quite a lot of nations. And you can see here that we successfully, along with a lot of other nations, reduced our death from coronary artery disease. And I think this is, obviously there's a lot of other things going on at this time, but I think this is a good example of how publishing data can concentrate the minds of health service administrators into trying to improve outcomes, particularly when you compare it across different systems. There's another study recently done by Rupert Pearce from London and colleagues and was published in The Lancet. This is the USOS study. And this is another example of outcomes research, comparative outcomes research. So they looked at 1 week in the year 2011, 500 hospitals across 28 countries, and they recruited about 50,000 patients. It was mostly non-cardiac surgical data. And they looked at crude mortality. And being as it was done from the UK, they used the UK as a sort of a benchmark, as the midpoint, the reference point. And you can see here there's quite a wide variation. So up at the top, as always, you seem to have the Scandinavian nations. And then at the bottom, you can see we have Latvia and Poland, and you can see the error bars, and even Ireland. And there was a lot of consternation about this. It caused quite a lot of anger, this study. As I think, particularly in Latvia, because it's actually based on a very small number of patients and a small number of deaths. So there's quite a few angry exchanges with the journal's editors about this. But I think if you were a health administrator in Latvia or Poland, you would actually look at the Scandinavian model and see and think, what are these guys doing maybe that we could adopt? So whereas this it can cause a little bit of distress, I think it can also just focus people's minds and cause people to work out what they can do better. I think it's that natural competitive instinct of ours. We want to be at the top of the game. You can even compare days of the week. And this was a study that caused quite a lot of difficulty because I don't know, back in the UK, our junior doctors basically went on strike over terms and conditions. And there was a lot of political wrangling, and this study was produced to suggest that mortality was higher at weekends. So everyone needed to work more at weekends for less money. So yes, you can even compare days of the week. And this is a picture which I think summarises how our current Health Secretary views the medical body. So let's look more at our field of endeavour, cardiac surgery. So this is our National Cardiac Outcomes Research Database, and this is something that the surgeons have collected. And centres are compared, but we can also compare over the years. And I mean, I started as a consultant in 2002, and a lot of changes had been put in place around this time. And what's interesting is if you just look at over a 5-year period, and I've circled the more elderly patients, because like everywhere in the world, we're getting more elderly patients coming for surgery. These are the higher risk patients. If you look at the patients less than 56 years of age, their risk is very low. And that hasn't really changed very much. But it's the elderly patients who really test our services and our skill, our anaesthesia, our surgeons, and our ICU services. And you can see there's a reduction from 8% mortality to 5%, just over a 5-year period. And I think this is real progress. You can also illustrate this graphically, and you can see whereas the error bars are still there, you can see this older demographic, these older people have a significantly reduced mortality just over a short period of time. So what drove this? Well, let's just go back to the beginning of this story. And some of the more senior people here may well remember and recognise this Bristol heart scandal. And you can see there's a lot of discussion about Bristol had double normal death rates. And this was a real scandal, and this was all over the press. And in a way, these guys weren't doing anything wrong, but this was how things were at this particular time. And it all came really from an anaesthetist, an Australian anaesthetist called Steve Bolson, who was working there at the time. And he'd just been appointed, and he was troubled by the fact that a lot of the patients he put to sleep for the arterial switch, a lot of the children, didn't do very well and they died. And he went to the hospital administrators about this. And they weren't really interested. And the feeling was, well, this is just high-risk surgery, this is the business we're in, this is what happens. And he wasn't really happy with this. And he made quite a lot of enemies in Bristol, and he made quite a lot of enemies around the UK. And in fact, at the end of the day, he had to leave the UK and go back to Australia. But he did some mortality research. He did an audit of mortality in Bristol Infirmary. And it was also compared with other centres across the UK. So for 1995, you can see if you look at the number died against the number alive for surgery in less than 1 year old, you can see there's two outliers on that graph. So you can see point 1 is an outlier in terms, it's a low volume centre with high mortality. And you can see centre 11 is a high volume centre with a low mortality, and they're both outside the 95% confidence bars. So there's a clear difference between these two centres. They are genuine, this is a genuine effect. So it's obvious to us now, looking at this, that centre 1 needs to go towards centre 11. But this wasn't obvious at the time. This kind of audit wasn't widely done. So around the same time, another doctor started to hit the headlines in our press. So this was a guy called Dr. Harold Shipman. And he was that most difficult thing to detect. He was a homicidal doctor. Now, luckily, we don't see much of this kind of thing, but it was truly horrific what this guy was up to. And he actually probably killed thousands of patients. And these were his particularly elderly female patients in his practice. So this was done retrospectively. But if you look at the same plot for this doctor, so the number died against the number of alive, and you can see the error bars, but there's only 2 years where he's within normal range. The rest of the years, he's well above the normal range. And you can see in 1997, he's particularly above the normal range. Now, if this data had been collected at the time, maybe hundreds of lives could be saved, but we didn't do this kind of audit back in the 90s. So anyway, coming back to where we were with this, coming back to the story, the Department of Health in 2002 decided that we're going to publish data on the clinical performance of consultants and their teams for use by clinicians and, crucially, patients. So from April 2004, 30-day mortality was going to be published. It's going to be put in the public domain. Every single cardiac surgery in the UK was audited, collected, and centres were inspected on the accuracy of, and their data was validated, and it was all put in the public domain. And you can see this is what's happened really from this time. So if you look at the bottom graph, the blue trace, that shows the change in mortality over from 2001 up to 2010. So there's a reduction in mortality. But the red one is very important. This is the expected mortality. So the risk keeps going up of these patients, the elderly patients with more comorbidities, but the mortality is going down. And this is what you can actually find on the internet. So if you're a patient, anyone can search this data, and you can put in the name of the surgeon who's going to operate on you, and this is what you get. And the one on the left of the screen is one of the surgeons at my institution. He's a good surgeon. He's near the green line, which means you're okay. The problem for this guy who works in another centre, you can see he's below the dotted line. So his mortality is genuinely higher than other surgeons. And this is a problem for this guy. His picture, his photos on the website. His patients can look at him. It's a real problem. And actually, when you're below this dotted line, it triggers an investigation by the Royal College of Surgeons, and I've been on a couple of these things. And it's very difficult. It's really distressing for the people in that centre to be called to account like this. But actually, the surgical establishment in the UK have looked at this, and you see some well-known names. Bruce Keogh was a real leader on this, and he's the medical director of our NHS. But they emphatically would say that collection of the data has changed things. Publication of surgical mortality is associated with a decreased risk. Now, there is a lot of other things going on at this time. So we've also rolled out TEE. We've probably improved cardiac intensive care. I think maybe the one big change we've noticed in the UK, or I've noticed since the data was put in the public domain, is that trainees operate a lot less. So consultants are there. The boss is there doing the operation right from the beginning, and he does the important bits because it's his name that's out there and it's his picture that's on the website. I think that's a particular difference. And I think as anaesthetists we've had to respond to that, and we've had to up our game, and we spend a lot of time in our cardiac theatres, and we don't let trainees do cases in the same way. Now this can cause problems because our trainees who come out, I think particularly in surgery, are probably not as good as they used to be. They're not as experienced. And I think there is a very steep learning curve when trainees start as consultants. But they would further suggest that there isn't evidence that higher risk patients are not being offered the option of surgery because mortality rates are published, which was one of the concerns. And if we look across at the States, they've done some quite interesting stuff with the data they collect, because they collect data in a similar way, every single surgery. And they produced this very interesting thing with the cardiologists, which they call the ASSERT project. So they've used the data in such a way to predict risk for patients. So if you're a patient having cardiac surgery, you can look and you can put your age in and your other risk factors, and you can see the chances of you surviving 7 years. Now obviously, statistics, there's lies and statistics, but this is quite good, and if you're a patient, I think this is quite a useful thing to be able to see. So these are some of the other benefits of collecting this kind of mortality data. So that's the first question. My second question was, should we be collecting mortality outcomes as anaesthetists? So this is something the cardiac surgeons in the UK raised and said, well, this is not just my problem. You're the guy who anaesthetizes the patients. You make all these decisions. You make the decisions about transfusions and point of care and whether you're giving FFP or not. So you share a lot of this responsibility. Your name should be up there as well on the internet. So we didn't really like the sound of this. So we thought about this. And if you look at how anaesthetic mortality is, maybe how we look at it, so we don't really think about it, I think, too much. We don't really collect data. It's not been pushed on us like it was pushed on the surgeons. But it was troubling that maybe this might happen. So we maybe report incidences of mortality under anaesthesia, and it's pretty low, death attributable to anaesthesia, but that's across all kinds of anaesthesia, which would include regional and sort of plastic procedures. And in our hospital, we collected a VLAD prop, so this is risk-adjusted and it's sort of stepwise, progressive monitor of your mortality. And we just collected this for internal purposes. So basically, this plot, if you're a good anaesthetist with a good mortality, you should be around the 0 line. So you may go up and down, but you should end up around the 0 line. But you can see we have one anaesthetist there, the pink trace, who's gone below. That's this red bar at the bottom. And that means he has a significantly higher mortality than the rest of the group. Now, this was a very eminent anaesthetist. So this was a concern. We didn't publish this, but we just looked at this as a department. But this anaesthetist also worked with a surgeon who had quite a large number of problems. So this anaesthetist mortality, we all considered this was due to the surgeon. It was their link to the surgeon. Yet, if we were to publish anaesthetic mortality, the anaesthetists who worked with poor surgeons, or surgeons who were struggling, would have a problem. So possibly an unintended consequence, if we were to publish this kind of data, would be that the stronger anaesthetists would work with the better surgeons, so the struggling surgeons will be pushed together with our weaker anaesthetists, which would be something you wouldn't really want to happen. Anyway, in 2015, in the United States, from New York State, this was published in Anesthesia and Analgesia, and they looked at the impact of anesthesiologists on the outcomes of coronary artery bypass surgery. And they collected about 8,000 patients. They looked at major outcomes, including death, and they tried to quantify this. And they used a logistic regression analysis using something called fixed effects modelling. Now, this is quite complex statistics, but as you can see, it's here presented. So above the line, in red, these are anaesthetists with higher mortality. Below the line, these are anaesthetists with lower mortality. You can see there's considerable variation from one to the other. And you can see the error bars, but the guys with higher mortality have error bars way above the line. So this would appear to be, these people have genuinely higher mortality. So then came all the editorials in Anesthesia and Analgesia. So you can see a lot of eminent commentators were talking about this. And they were saying, well, anesthesiologists do make a difference. And this was quite important in the States to some extent, because They have a very good remuneration. In a way, they wanted it to be known that they did make a difference, but it was still uncomfortable. And the New York State decided they were going to publish all anaesthetic mortalities by name and put that in the public domain the following year. So a lot of people were really worried about this. And a lot of people were thinking, I'm going to have to ditch the surgeon I work with. I'm going to have to find another surgeon. So we discussed this in our society, and Ravi was part of this, and we had a bit of soul searching, and we discussed, and we decided to do our own study. And this is something we published last year. So our study aims, we collected 110,000 patients' data because we had it all from the surgeons and we had the names of the anaesthetists there. And we wanted to quantify this variation in risk between different anaesthetists, and we collected that data over that 3 years. We asked some other questions like, was there a safe minimum annual caseload? But the question we really wanted to answer was, should we publish individual anaesthesia mortality? And should we put that into the public domain? Is there evidence that that would be an effective thing? So we used a slightly different methodology and slightly different statistics to the other study by Glance. And we use random effects regression analysis. So random effects, when you have grouped data, so anaesthesia linked with surgeons and with patients, you try and separate out each of these things, that grouping effect. On the two graphs here, so you can see the one on the left shows an anaesthetist forest plot which is adjusted only for case mix, so the patient and a patient risk, and the centre risk. So what are the cultural factors of that centre? The one on the right shows when you adjust for surgeon. So obviously certain anaesthetists often work with certain surgeons, and that can be quite a fixed linkage. It's not random the surgeon you work with. You have a relationship and you work with that surgeon a lot. But when you take the surgeon out, you can see there's actually very little variation in anaesthetic mortality. But it's interesting, so this is the surgical plot. So you can see that surgical variation with and without adjusting for anaesthetist, and there's actually no difference for surgeons. So who the anaesthetist is not so important in terms of mortality. And actually, if we look at the effect of surgeon on mortality and anaesthetist on mortality, you can see there's a difference there. But actually, they're both still small. So maybe there's been an over-focus on the effect of surgeon on mortality, because you can see all the risk lies with the patient. So 96% of the perioperative risk of death lies with the patient and their risk factors. So there's a strong message here. So firstly, the impact of it, the anaesthetist was minimal. And an editorial went along with this and said we shouldn't publish our outcomes. They shouldn't be put in the public domain by an anaesthetist. It's not evidence-based. So this was a very useful piece of research because that put that to bed. And actually, interestingly, there's a fair bit of discussion about this in the States, and Glance went back and looked at his research, and he used random effects modelling rather than the fixed effects, and he actually came up with the same conclusions. So the paper wasn't redacted, but he republished the data. And just as a sort of coda to this, I went to the FCA to speak last year in San Diego, and I went to see Dr. Glance talk, and this was his kind of summary slide about what happened to his idea, from the light bulb moment to the toilet. Although I was slightly disappointed he didn't mention our research in how he realised he needed to redo his research. Anyway, so I think the message from this, apart from us not publishing our data, is it's all about the patient. The patient's to blame. But it's the patient's risk factors we really need to focus on, I think, and not soul search about what we do so much. So I'm nearly out of time, so I'm just going to comment briefly about what we're now trying to do with post-surgical intensive care, because this is a place where conflict can really flourish. and there's a lot of different practices in different cultures, different countries, and even different centres in the same country. And there's a lot of varied practice about who does ICU within the UK. Our general intensive care units have collected mortality data, and not just mortality, but unit-acquired infections, sepsis admissions, bed days, high-risk mortality. So every single patient in general intensive care in the UK is now here. This is in the public domain. You can see it's a funnel plot, risk-adjusted mortality. Not by name, but by centre and by unit. So we don't do this for cardiac, really. This hasn't been done for cardiac, but cardiac coming into this. And there's a number of predictors of ICU outcome. There's a number of scoring systems available, from Euroscore, which is pre-op, to ICU admission score. And we've now started to publish our hospital mortality for cardiac intensive care units. Now, this is an early one. I think this is from 2013-14. There's only 5 units. So obviously the funnel plot's very wide, and it doesn't really change that much with volume. But this is early days. We've got 35 cardiac units. So when a cardiac surgeon comes to me and says, listen, my data's published, yours isn't, I can say, well, actually, our data is published, our data is in the public domain. What I do is valid, my decisions are valid because I am accountable. So it's been quite useful for me to discuss that with cardiac surgeons. We've had some evidence. I recently wrote this editorial about where we are with this project. We're calling this the assessment of risk in cardiothoracic intensive care. And I think these are the key predictors we've discovered from really looking at 17,000 patients within cardiac intensive care across 3 years. And these are the things that are really important. It's very similar to what's important in general intensive care. These are what discriminate between good units and bad units and help you to quantify that risk. So now we're actually publishing with general intensive care, although you can highlight the cardiac units and it doesn't really come through here, it's a slightly different blue. But you can look at the units that are like you, and we now have 12 units signed up, and we hope to get all 25. We're linking up with some Australian units, Tim Coulson and colleagues, who've done some very interesting research in Melbourne, and they've been looking at pre-op, the surgical pre-op risk prediction score with the ICU admission score, and looking at the change in risk that happens during cardiac surgery. And they say this is a very good at indicating true differences in risk between centres and between surgeons. So that's something they're actively investigating in Australia. This is what's actually validated now for ICU outcome scoring systems, and this is what's validated for cardiac intensive care. So this is work in progress. This is something we're trying to do in the UK. And what I'm here to do is not say what you should do, because your questions will be different, your answers will be different. All I'm really doing is, I think, is sharing practice about where we are with this. And I think I'm going to conclude there, but my conclusions are, I think wherever we are, we must find a way of identifying poorly performing surgeons and anaesthetists and poorly performing centres, and get the bad centres up to where the good centres are. And there's different ways of doing that, but I think that's something we all need to do, particularly in the job that we do. Accurate comparative audit seems to be associated with improvements in outcome. I think we've shown here that there is no justification to publish anaesthetic mortality data, and I think we're discovering that ICU risk-adjusted data should be able to provide us with good outcome research, and also will help us to investigate what good centres do, what other centres do, and we can look at some specific questions between centres. And I'd like to stop there, and thank you very much for your attention.